Well, good morning, everyone. My name is Charlene, and as a clinical research specialist at InBody USA, I want to welcome all of you to today's webinar in our InBody Presents series. Our special guest is Nick Harman. Today, he will be speaking to us about his research on phase angle and cancer rehabilitation and its implications for cellular function, treatment, and prognosis. Nick is the University of Northern Colorado Cancer Rehabilitation Institute graduate assistant, and he is currently pursuing his PhD in exercise physiology. He has experience with several different clinical populations in the field of exercise rehab, including spinal cord injuries, cardiovascular disease, and cancer. His duties as a graduate assistant at the UNCCRI include supervision of cancer exercise specialists, assisting with exercise assessments and interventions, and overseeing ongoing clinical research studies. He also instructs a course in exercise programming for cancer patients at UNC. At the end of the talk, attendees will have a chance to ask Nick questions by adding them to the Q&A section. So without further ado, I'd like to welcome our guest speaker, Nick Harman, to join us. Thanks for taking the time to be here with us, Nick.
Thank you, Charlene. All right, well, once again, thank you all for coming today. And thank you, Charlene, and your team at InBody for hosting this. Very excited to talk to you all about phase angle and how cancer rehabilitation can really aid in this measure, discussing what it is, why it's important in our population, and where we can take it, how we can use this value, this measure, and really apply it to all facets of the cancer treatments and rehabilitation spectrum. All right, so just a little background about where I am at and what we do here at the UNCCRI. So we're located in Greeley, Colorado on the University of Northern Colorado campus. We were founded in 1996 by Dr. Carol Schneider. So Dr. Carol Schneider was actually a cancer survivor herself, and being a bright mind in exercise physiology, when she was going through her treatment options and told of the potential side effects of the various forms of chemotherapy, radiation, and others that she was presented with, realized that a lot of these potential side effects and complications could be remedied by exercise. And she took that idea, ran with it, and expanded it into what we have today. That ultimately developed into our goal of the facility here, which is to investigate the role of exercise in cancer rehab, and specifically in how we can use exercise to mediate the side effects of cancer and its treatments. All right, so our program is comprised of cancer survivors at all ends of the treatment continuum, which is to say we have individuals who come here who are pre-treatment, so they're getting ready to undergo whatever their primary form of treatment is and initiating that plan. In treatment individuals, so those who are actively receiving treatment, as well as individuals who have completed their treatment plan and come to our facility after that. Ultimately, though, we do have three pillars that we pride ourselves on in our facility, which is service, which is the main component, providing the rehabilitation for cancer survivors. Education, which extends to our cancer survivors and clients themselves, and educating them as to why coming here is important and how it will better their health. But education extends further than that. We have programs geared towards graduate and undergraduate students via classes at the university, as well as internships. And furthermore, we have opportunities where we go out or bring people into our facility and train them on what we do here. And then last but not least, where I spend most of my share of this pie of pillars is in the research side of our program. So utilizing the values we generate here, or implementing different interventions based on the current literature with our clientele, and seeing how the additive effect of exercise coupled with whatever else we might be measuring could provide benefit. All right, so at our facility, our model of rehab is the phase program. So just a brief overview here. This is a model of rehabilitation that's comprised of 4 phases, but the 2 we're gonna primarily look at today with regards to the research that I'll be presenting is phase 1 and phase 2. So a quick definition of what those mean. These are 2 phases that upon intake, a client could enter as. So phase one would be any individual coming to our facility that is actively undergoing treatment. And treatment in this sense for us is strictly chemotherapy and or radiation. A client could also enter into our program as a phase two individual, which is our definition that we'll use here today is someone who has completed their treatment or their treatment plan did not include chemotherapy and or radiation. The subsequent phases, phases 3 and phase 4, are going to be comprised of individuals who have graduated through the first two and continued on in their rehabilitation. Each one of these phases carries its own goals and its own intensities, its own programming approach, but ultimately, all of our individuals, regardless of phase, will come to our facility and perform 12 weeks of rehabilitation. They'd ideally come 3 times per week, and each session that they attend will be 60 minutes in length. All right, so upon entry and every 12 weeks, we conduct an exercise-based assessment. This is meant to provide us with information on an individual's physiological health as well as psychological health. So this assessment is going to be comprised of several different tests for physiological measurements, which will include measuring of vital signs, body composition, spirometry, balance, cardiovascular health, muscular strength, muscular endurance, and flexibility. All right, the psychological assessment is conducted via surveys in our facility, generating measurements of fatigue, depression, quality of life, as well as sleep quality. All right, we use these values to establish an individualized exercise prescription. So every person that comes to our facility is going to have their own unique approach to their rehabilitation. You know, they'll have some grouping variables that will classify them in a specific phase, but even within a phase, a client will train differently from one person to the next. All right, and then the key tool that we'll use to generate the phase angle value, which we'll get into here in a second, is our InBody 770 machine. So our InBody is part of our body composition wing of this assessment. And it's going to generate a wealth of values to include a segmental analysis of lean tissue, body fat, hydration status, and of course, phase angle. All right, so moving into phase angle, what is it? What are we talking about when I say this term? So phase angle is a measurement of cellular reactance and resistance to a bioelectrical impedance. So some impulse that travels through the body, reaches a cell, and is delayed in its ability to cross the cell membrane. With someone who has a low phase angle, what that will imply to us is that the membrane has lower integrity and thus allows that impulse to travel more readily across the cell membrane, whereas a higher phase angle would delay that response for a longer period of time relative to the individual or to an individual with a low phase angle. All right, so again, just kind of putting this more into words here, but some factors that could affect the impulse, how quickly it gets to a cell membrane, and how readily the impulse can travel across the membrane is the hydration status of an individual, where is their body water distributed, and then, of course, as I mentioned, the integrity of the cell membrane itself. From a mathematical standpoint, this value is calculated as the inverse tangent of the reactance of the cell membrane and the resistance to the impulse of the cell membrane. All right. So again, the faster that we can achieve an impulse traveling across that membrane, the lower the phase angle will be. So it's important to realize that fact that will get us to that phase angle value. All right, so why do we care about phase angle in our population? Well, I have to break this down into 2 different categories. First, there's the clinical implications of a healthy phase angle. There's several aspects that can go into this. There's a prognostic value of having a high phase angle. Phase angle has been shown to evaluate nutritional status. It can be an indicator of being in a malnourished state. Fluid distribution is a factor that phase angle can lead to revealing, how our body distributes water either extracellularly or throughout the entirety of the body. And then quality of life, higher phase angles, as we'll come to see, could lead into a greater quality of life for someone in a clinical population, in our case, a cancer survivor. And then the second category is the benefits of a healthy phase angle, just in general. So for the cancer survivor, this could imply greater tolerance of treatment. This goes hand in hand a bit with that prognostic value in the clinical wing, but in terms of one's ability to come in, receive their treatment, and hopefully delay or alleviate the onset of significant side effects afterwards, this could play a role in that. Improved cellular function, and what I mean here is specifically having greater integrity of the membrane, leading into greater functionality throughout the day. Maybe this will delay fatigue onset. Maybe this will help prevent fatigue onset and allow someone to maximize their independence, maximize their ability to function on their own and without the need of another's assistance. Reduce hospitalization or length of stay. So utilizing, again, that prognostic value of the phase angle and translating that into a more personable approach, having a better tolerance of treatment, a better prognosis would imply less need to go to the hospital. And ideally, if there's an admittance required, reducing that length of stay. And then last but not least, going in both wings here is an improvement to the overall quality of life of an individual. So hopefully that becomes clear throughout this presentation. All right, so before we get too far into the direct implications of phase angle on cancer, I want to highlight a bit the treatment side effects for cancer and how that could relate to phase angle. All right, so there's several different side effects that come into play with receiving chemotherapy, radiation, the gambit, and these are going to impact, or phase angle will have an impact on those side effects themselves. So some that we've already mentioned here, disease prognosis is going to be a big one that we're going to talk about. Skeletal muscle, lean tissue, more broadly, those characteristics with regard to a phase angle, how these tissue beds are impacted by treatment. Phase angle could give us an idea of how to approach that, what to interpret in terms of the severity of some of these side effects at the skeletal muscle level. All right, fluid distribution and retention. So what I'm specifically referring to here in the cancer population is lymphedema, a very potential side effect that could arise in certain populations given their treatment plan. And then I'm also going to discuss the extracellular water to total body water ratio, which phase angle plays a role in as well, and which is shown to be abnormal at times in the cancer population. All right, so getting into cancer and phase angle, starting with that disease prognosis and survival, just highlighting a study conducted by the Gupta group in 2008. They found that a higher phase angle was indicative of greater survival over the course of a 5-year monitoring of cancer survivors in this case. So you can see here when looking at this graph that those individuals, the solid line are all of the population, or all of the individuals within their population that had a high phase angle versus the dashed line where individuals had a low phase angle. The survivability, the probability of survival after 5 years was just under 40% in those with high phase angles and just above 20% in those with low. So it's important that with this value, as we start to learn more and generate more research with phase angle, that survivability and prognosis are looked at as well. And this in general could lead to greater tolerance of treatment. Individuals that have a greater survivability with a higher phase angle, maybe they're tolerating their treatment better. Maybe those dosages of treatment could be manipulated. Maybe they could handle a higher dose, or maybe they don't need as high of a dose because their body is in a state of greater probability of survival. A lot of this is to be determined, but it's important to think about this as we continue on with this research. All right, the next area of interest that I'd like to talk about with cancer and phase angle is cachexia. So cachexia by definition is, in our case, a disease or a cancer-related loss of lean tissue. And being so, losing lean tissue over time, or as a result of the cancer, as a result of the treatment, we see a lot of low functioning characteristics of those who come into our facility in a cachexic state. With regards to phase angle has been shown to be a predictor of muscular strength in our population. So a low phase angle, shown here by the Norman Group in 2015, resulted in less hand grip strength generation in both males and females. So looking at this graph here, on the left, the black box is males who were in the top 5th percentile of phase angle, showcasing a significantly higher hand grip strength than those on the right, the white box for the males being in the bottom 5th percentile of phase angle for their population. Same exact response was seen in the 2 boxes on the right with females. Similar response occurred there. Now, the next question that comes to mind when we're dealing with cachexia, especially in our population, is, well, what's the influence or what is the relation of phase angle in sarcopenia? So sarcopenia being the age-related loss of lean tissue and muscle. Well, our population, our clientele, is comprised pretty heavily of individuals who are approaching or in that age group of age-related loss of muscle mass. Couple that with cachexia, well, what does that say for us? Well, with regards to sarcopenia, phase angle is not found to be a significant predictor of its onset, which is, quite the conundrum, I suppose. Why is it that it's a predictor for cachexia, but not a predictor for sarcopenia? My initial thoughts here are that the metabolic profile of a tumor, the treatment that's received in cancer, leads to that greater loss of membrane integrity, resulting in a lower phase angle, and thus leading to less nutrient availability, metabolic substrate availability for skeletal muscle, for lean tissue, for them to adequately, reach a healthy profile. Whereas with sarcopenia, it could be a more controlled onset of muscle or lean tissue loss that, when taken by itself, is not necessarily seen in an otherwise healthy aging population. But this does give us a bit of a double-edged sword with our population. We want to know if sarcopenia in the cancer population can be influenced or can be indicated by a change in phase angle. So need to dive a little bit deeper into that. All right, so lymphedema is another big area of concern, especially in the clinical side of cancer and on the patient side. With lymphedema, so just a little quick refresher here, our lymphatic system being a web of vessels circulating throughout the body that will just take up and distribute lymph fluid for excretion or just maintenance throughout the body. A big cause of concern with cancer is loss of integrity along this lymphatic system and seeing some of this lymph fluid drain into the extracellular space. Well, with phase angle, we find that phase angle can be used as a predictor for lymphedema. Coupled with some other things that we'll touch on the next slide, it could be a very powerful tool in determining lymphedema risk. But the issue here is that the mode of bioelectrical impedance analysis, or BIA, highly depends or is indicative of how phase angle could truly be used as a predictor. So the mode that's used is of great influence for using phase angle and assessing this risk. A lot of the evidence currently out there is conflicting, but most of the literature does point to using phase angle as a valuable marker for risk assessment in this population. And one interesting tidbit is that it's also useful in directing management of lymphedema. So there's some, albeit not much, evidence that phase angle as a predictor for lymphedema could help guide physical therapists or whomever might be performing manual manipulation therapy in the amount of aggressiveness they could use in approaching that patient, that client that they're trying to redistribute the lymph fluid for. All right, so our next measurement of fluid distribution and how phase angle could play a role in this in the cancer population is looking at this extracellular water to total body water ratio, ECW to TBW. So what we find here is that ECW, this ratio is a significant determinant of phase angle. It's possibly due to changes in fat-free mass in our individuals. One thing we'll see here, and I'll touch on in the data, is dependent on what segment of the body you're looking at will dictate the degree of phase angle that's found there. And what I find is that a lot of our data shows greater phase angles in the areas where we hold on to the most fat, and lower phase angles in the area where fat-free mass may have been deterred or decreased as a result of cancer treatment. All right, so this same situation, this alteration to this ratio can be found in other populations. Malnourished individuals see a change in their water ratio here, as well as septic individuals and physically inactive populations. Furthermore, obese individuals have higher ratios here due to their changes in cellular fluid distribution, as well as their hydration status. And I bring these different populations up because we do intake individuals who are potentially physically inactive, could be classified as obese. So couple that with their treatment, couple that with their cancer itself, we could see large or significant fluctuations in phase angle, and definitely seeing lower phase angles at the onset of their rehabilitation. But I do want to mention here, when we look at, and this is an example provided by InBody, and when we look at how the extracellular water to total body water ratio reacts over time, one thing I really like to highlight here is the influence, or sorry, the trend of percent body fat. As it decreases, we do see changes and decreases in the ratio for water. This is great. You know, we need more research to establish this trend, but phase angle could also be coupled in with this. We could use phase angle in conjunction with changes to percent body fat, you know, indicating upregulation of lean tissue production, redistribution of cellular water, and then using the phase angle as a marker potentially for changes to the cell membrane integrity, providing that avenue. Furthermore, using the InBody information here, you know, they have developed a use of this ratio in determining lymphedema risk. Higher ratios of extracellular water to total body water are indicative of increasing risk of lymphedema. And we've already seen that phase angle has the potential to be an indicator for lymphedema risk. So coupling those together, we could just further ingrain and establish that risk and thus determine how to best tackle lymphedema. All right, so the role of exercise. So how is exercise coming into play with the phase angle? So we do see in other populations, healthy and aging, that phase angle can improve with exercise. However, one important thing to remember with all exercise, but especially when we look at the phase angle here, detraining can occur. And detraining being the state after exercise or after one stops continuing an exercise regimen, where all of those positive changes that they've incurred start to lose their they're no longer evident. They actually start to regress back to a potentially sedentary state within those different physiological systems. And that's seen here as well with phase angle. The Sardinia group in 2018 established this detraining effect extends to phase angle by showcasing or taking a cohort of individuals and training them for about 12 weeks and then monitoring them up to 12 weeks post-training and seeing that detraining did result in a loss. So you can see here training led to an increase in phase angle, whereas detraining over time reversed that effect. So it's important that we recognize that phase angle, just like physiological systems in the body, can undergo the effect of detraining. All right, so this begs the question of which mode of exercise is going to provide us with the greatest amount of benefit. I like to break this down, or I'm going to break this down for our presentation into three different groups. First one being aerobic exercise. So, you know, does aerobic exercise provide benefit for phase angle? Well, there's surprisingly little research to support this. There's surprisingly little research out there in general on aerobic exercise on its own and its influence on phase angle. A lot of the studies I came across utilized a walking protocol or a protocol that they classified as aerobic but defined as any exercise in their intervention. So there is need for a formal aerobic intervention to really establish if there is a significant improvement in phase angle here. The second category is resistance training. So, your traditional, what most would traditionally think of as a weight training protocol, it does extend out to more than that. But we do have literature to support resistance exercise as a beneficial form of exercise for phase angle improvement. The DeSantis group in 2016 showcased here, looking at the far right column on this graph, a significant change in phase angle over the course of their resistance intervention. This was in generally healthy individuals, so we should translate this into a cancer population, but the proof of benefit is there. And then last but not least, a combined mode of exercise, which is what we practice here in our facility. We break our sessions into periods of aerobic training, resistance training, as well as flexibility training. And right now we'll showcase what the results of an intervention such as that showcased in our population. All right, so as we wrap up and move into the data, when we look at what we know about phase angle and its influence either in cancer or in the generally healthy and aging population, we know right off the bat that when we provide exercise for a cancer population, there's a benefit there. So it should be at least hypothesized that this benefit will extend to phase angle in the cancer population. The role of phase angle in our cachexic and lymphedemic patients, there's literature out there that's showcasing we can see some improvement, but we really need to formalize that. We also need to understand how phase angle is going to react after treatment's ended. We need to understand what the outlook would be in terms of establishing a healthy phase angle once one has completed their treatment. And then finally, using all this information to ideally establish normative data, specifically for the cancer population, but also extending that out, if possible, to the generally healthy population. Right now, there is no normative data out there on phase angle. There's just general consensus on what could be considered a healthy phase angle. Right now, that's anywhere between 5.5 to 6 as just a solid number there to indicate phase angle as being in a healthy state. All right, so moving on into phase angle during treatment. So as I mentioned throughout this entire presentation, chemo and/or radiation are going to compromise cancer cells and potentially lead to side effects, but they're also going to compromise healthy cells or have the potential to do so. This is going to extend to the membrane. This is going to lead to those alterations in phase angle. The membrane could be leaky, it could be porous as a result of these treatments and their negative side effects. And as we see already in the data presented, phase angle is going to react or at least provide some value in the cancer population, which could especially be important when we have clients who are undergoing treatment. So starting there, looking at our phase 1, and recall these are individuals actively receiving chemo and or radiation, what do we see in our facility in terms of their changes to phase angle after our rehabilitation period? Well, when looking at these data, starting off with what we define as upper body phase angle, being phase angle in the right arm and in the left arm, we saw significant improvements after 12 weeks to both segments of this area of the body. Right arm phase angle, at the onset of their rehabilitation was at a 4.55 and improved to 4.68. Whereas the left arm phase angle began on average at intake at a value of 4.45 and increased to a value of 4.47. All right, and looking at phase angle of the whole body in these individuals, we found that there was yet again a significant improvement in their phase angle values. Whole body here beginning at just above 4.5 and ending at just under 4.7 after 12 weeks. And this is taking into account percent body fat. So using that as a potential factor here, or at least looking at the potential body fat, we found that it was not a significant influence on the phase angle values in the whole body. However, our other values that we measured, and this brings up, other areas to go down, the lower body phase angle, which we define as left and right leg phase angle values, as well as the phase angle of the trunk, our fourth area of phase angle analysis, neither showed significant improvement for our phase 1 or in-treatment individuals. And that begs the question, going back to, especially in the trunk, areas of fat distribution, does this play a role here? What would it look like if an individual came in a state where they weren't potentially classified as obese or some other disorder that could cause redistribution of water, of other tissue, adipose tissue specifically, into the trunk? Would this influence their phase angle? That's to be determined. Looking at our individuals who come in a state of post-treatment, so our phase 2 individuals, what we see here, just looking at other side effects we already know tend to persist post-treatment. We know that things like fatigue, things like neuropathy, cognitive impairments could potentially be felt for months to years after treatment has ended. And as we'll see here in these data, phase angle is not an exception. So we saw that similar to our phase 1 clientele on intake, they came with a low phase angle in our phase 2 groupings. All right, so we're going to break this down a little bit more here, beginning with the whole body phase angle analysis. After 12 weeks, we did see a significant improvement to this value. We saw these individuals go from a phase angle of 4.5 to about 4.7 after 12 weeks. And this is similar, if we think back to those phase 1 groups, to their values, which begs the question is, on the global level, on a whole body level, does phase angle, is it a lingering side effect that we see with fatigue, that we see with neuropathy? Is this something that can really persist after treatment without the intervention of exercise? Looking at our peripheral analysis here, so going back to that upper body phase angle, we saw yet again significant improvements to phase angle in our post-treatment grouping, in our phase 2 grouping. And now we also saw a significant improvement in the lower body. We saw these individuals increase in both the right and left leg phase angles after 12 weeks of exercise. Yet again, the one area we did not see significant improvement, and I have the graph here for trunk's phase angle in this group, what was in the trunk. And one thing, especially when looking at the values of phase angle for this grouping in particular, was that their phase angle was 6.1, which, thinking back to the general consensus of what's a potentially healthy phase angle, would put them into that value, albeit no significant change. They were 6.1 12 weeks later. Which begs the question, is more time necessary to cause changes? And when we see those changes, are they going to manifest in the trunk phase angle? Would loss of adipose tissue cause this value to decrease, increase? Would that being replaced by lean tissue cause it to remain the same? That's something that's still to be determined. Furthermore, moving into the conclusions here that we can see, or that we can make from these data, prescribed exercise is providing benefit. Especially with regards to that in-treatment grouping, we're seeing benefits there. We're also seeing benefit to our individuals who come in post-treatment. These changes that we see give us insight into how exercise can provide benefit, can help protect cellular health in our population, whether they're in treatment and then when they do finish their treatment. Whole body and upper body phase angle in our phase 1s saw benefit, but we didn't see that benefit in the trunk and in the lower body. So given that lack of improvement, it might be necessary to look at longer periods of exercise to really see if those values can significantly change despite the influence of treatment in this situation. It's going to require a little bit longer of a measurement period, but ideally it would provide us with the information we need to better understand phase angle in a in-treatment population. All right, so the directions that we should really take with regards to this phase angle value and what we can do as healthcare professionals is start to look at multidisciplinary approaches to the cancer rehab setting, and then specifically those values that could be influential on phase angle. So can we institute some sort of an intervention in conjunction with exercise that could promote lean tissue, decrease body fat percentage, help with hydration, help with nutrition? You know, the first avenue that seems apparent here is institution of a dietary intervention, you know, either on its own or ideally in conjunction with an exercise intervention here. You know, what do we see with phase angle when we start to look at this from a multidisciplinary perspective? Given the fact that we don't see significant shifts in phase angle all across the areas that we analyze, you know, maybe we require greater shifts in lean tissue and fat tissue mass and distribution to see proper changes in phase angle. Now, this is especially true, in my opinion, in the trunk. You know, I'm interested in seeing what those phase angle values in the trunk will look like when we start to see shifts in lean to fat mass distribution. This is going to have to be viewed over a more longitudinal lens, but I believe that the benefit will present itself. And then in terms of cellular function, you know, we talk about, you know, better independence, better functionality, greater quality of life, but we need to start to look at how cellular function is truly improving outside of what we use now, which is subjective measurements. You know, we need to look at this aspect of cellular health from a more benchtop lens to start, especially in looking at human cells. So in terms of the direction here and really establishing, knowing for a fact that the function of a cell with increasing phase angle is improved, we have to transition back to the wet lab space and then translate back to our human population. All right, so that being said, I'd like to acknowledge some individuals who were really supportive in analyzing these data, as well as writing up our abstract and poster for this data. My mentor, Dr. Reed Hayward, as well as Nate Croto, who is one of the co-authors on the abstract, a fellow graduate student here. And then the staff and everyone at UNCCRI. So our clinical coordinator, Michael Lazio, our program manager, Casey Condrotis, as well as all of our staff, our clients who come here every day and work so hard, and our students who are really, you know, the backbone of what we do. They're amazing. I can't speak highly enough of them. And then last but not least, Oncology Rehab, our physical therapy group that we're partnered with here to provide cancer-specific physical therapy to our clientele. They do a great job at what they do, based out of Denver. All right, so before we move on to questions, I just want to please feel free to contact and connect with us here. We do offer workshops on site at our facility, and we are willing to go out to other facilities, you know, when that capability is, you know, back in our lives. We offer internships for undergraduate and graduate students, both in the US and internationally, if they'd like to come here and intern with us, as well as collaborating on research. So our contact information for our facility is below. You see our phone number, as well as our email, uncCRI@unco.edu. And then I have our web address here, but I do find it's much easier to just Google UNCCRI than to have to memorize this entire web link. But if anybody does have or has need for this contact information, I can definitely supply it through our InBody team here. All right, and that being said, thank you all for your time. I'd be happy to answer any questions. And again, if you have any questions that arise after this, please feel free to contact me.
Well, thank you so much, Nick. We appreciate you sharing your research with us as well as insights into your next steps. As you mentioned, we will be moving into our Q&A at this time. So I do see we already have some questions for you from our audience. Let's take a look at our questions here. Our first question is, we've seen the positive effect of keto diet on cancer patients through the research, and you did mention in the future looking into the effect of nutritional status or diet changes on phase angle. What in particular would you pay attention to, either the value or the output, outside of looking at the effects of exercise alone?
Yeah, so with regards to a dietary intervention, you know, I think with those sorts of studies, especially now. I found there's a lot of research coming out with the microbiome of the gut being a value that could lead to that with use of a nutritional intervention could lead to greater health across the body. So if we're not focusing solely on phase angle, I'd be interested in seeing how the gut microbiota it responds to exercise, the dietary intervention, and then maybe looking at how that translates to the phase angle, which, providing more nutrients, providing better quality of foods could lead to that improvement in cell membrane integrity, because our membranes are built up of macronutrients such as fats. We need those readily available and readily able to improve the integrity of the cell membrane. We actually did a study here about a year ago using kefir as a supplement to look at not cell membrane health, but just generally the health of our individuals and how better their gut microbiome looked with exercise and kefir or lack of kefir with exercise. And we saw pretty good results. So one of my colleagues, who's Dr. Smoke, who's no longer at UNC, looked at that study and is pretty well versed in how that appeared in our facility, and it's great. I think I'm not as well versed as how the keto diet would impact phase angle, but it's out there, and I know there's a lot of literature and a lot of groups that utilize the keto diet in cancer from a metabolic standpoint. It'd be interesting to see how that translates to a measurement of membrane integrity with this.
Definitely. And as you continue again moving forward your research, of course, we'd love to see what insights you do have moving forward and its effect on cancer rehab. Looks like we have another question here from Paulette. Paulette says, "Thank you, Nick. I enjoyed your presentation." And she's wondering if you are able to comment on what is the mechanism of improved phase angle with exercise, and why does exercise improve phase angle?
Yeah, so in terms of the direct mechanism, I'm not totally sure. I think that's why we need to go back to the wet lab and really look at what factors are potentially upregulated or downregulated as a result of impaired phase angle. But with regards to exercise specifically, my initial thoughts are that the way our bodies respond to the stress of exercise, the way we're forced to adapt and adjust at the cellular level, those factors that we know are upregulated and require a more stable environment to do so could force or cause some sort of constitutive pressure to build on the integrity of a cell, if that makes sense. I don't want to reach too far with this, because I feel like this is something that we're really going to need to focus on if we take this further and then translate it into a wet lab setting, because that's where we're really going to find those responses. We're really going to be able to say this is upregulated, and as a result, we see a higher phase angle. But with regards to exercise specifically, my opinion is that it would be down to the stresses related to an exercise intervention and how the body adapts and the environment that's necessary for the body to adapt internally.
Great, thank you for sharing that. Now, our second question here is, do you assess urine-specific gravity prior to phase angle assessment? And what is the frequency with which you do assess phase angle?
Yeah, so great question. So we have urine analysis equipment at the university. We don't have them in our facility. So we do not have measurements of urine analysis at the assessments. It's something that we can implement. And it would be very interesting, especially with all of this literature supporting hydration, or at least just fluid distribution on phase angle to look at. We haven't looked at that yet, but we assess phase angle unless requested by the client once every 12 weeks. In the case of certain situations, especially with our cachexic individuals, we'll perform these body composition analyses more frequently. But in general, it's a 12-week measurement. So we look at that at the initial assessment and then at every subsequent reassessment of their parameters.
Awesome. Now, and in terms of continuing on with the methodology of your research, we have a question here that's asking, were the data paired analyses, and can you comment on differential data? For example, did all study participants complete follow-up with cancer? Is it possible that the sickest dropped out, leaving a healthier population with higher phase angle at the end?
Yeah, so that's a great question. And it was paired, and it was just comprised of individuals who completed their 12-week intervention period. So I acknowledge that fact. I acknowledge that, we might have had individuals drop out during their 12 weeks. And, maybe they were individuals who had either a very low phase angle or, ideally a higher phase angle, indicative of greater health. There's a variety of reasons people might not continue. Resuming treatments, the biggest one, I would say. So that's entirely possible, and I acknowledge that. And unless those individuals re-enter our program, we don't have the system to follow up and bring them in, and even then, they've broken up the 12-week intervention period that we want them to have in sequence. Yeah.
Great, thank you for sharing. Looks like we're having a lot of questions coming in here, so I'm just trying to filter through. As they come along, a lot of people are saying thank you so much for the presentation. I'm very interested in your research here. Looks like we have another question, and it's asking, do you have data on a population of cancer patients without exercise to see how phase angle changes without that?
So we do not. Yeah, and that's, again, I recognize that that's a big one. And for me personally, we've gone into recruitment for a non-exercise wing, and we've made strides to establish a referral avenue of what would be considered a control population. But when it comes to recruiting there, I've had individuals who come in and they say, yeah, I'll come in now, I'll come in 12 weeks later, and then they get here and they see what we're doing, they see what the plan of what we do, of what we would do, and they ultimately decide, hey, can I join instead? So that actually tends to be a factor that limits our ability to recruit individuals that would be considered a non-exercise or a control-based group for our facility. It'd be interesting to see if this could translate into an inpatient setting, or at least in a hospital or clinical setting, where we could potentially have more access to those who, for whatever reason, can't participate in an exercise intervention at the time, and see what their phase angles are up until they're able to enter into a rehab program, if they want, of course. But yeah, that's been a big one for a while, trying to establish that avenue and really having a grounded and ingrained stream of referrals for those who just want to help out, which we do get, but not as frequently.
Mm-hmm. Now, in speaking on exercise, kind of the opposite on that with detraining. So would the detraining and therefore fluid volume reduction affect phase angle, or do you think it would be more tissue specific?
Good question there. I'd venture that it would be more on the fluid side of things. You're going to get that lean tissue loss, but what we see already in individuals who are physically inactive, having greater extracellular water to total body water ratio, as well as individuals who are obese, showcasing the same fluid distribution, I would say that the fluid factor would play a bigger role, even in the detraining effect. Maybe immediately that's not the biggest factor that would impact the decrease in phase angle, but ultimately that would be my assumption, is that you're becoming more inactive, you're maybe transitioning into a state of greater adipose tissue growth and entering into a state of obesity, and that's what's causing those shifts in phase angle, or could potentially influence those shifts in phase angle, if any, there.
Mm-hmm. Now, in talking about the improvements of cellular function and of course phase angle and its relation to cell integrity, we have a question here that's coming in. It says, how can phase angle evaluate improved cellular function when it evaluates the integrity of the cell membrane?
Yeah, so the big thing there is that with the cell membrane, if it's porous, if it's leaky, what we're limiting there is the surface area or the potential surface area for, let's say, protein expression, building of different channels that the cell could use to regulate its flow of ions, other factors, metabolic factors, whatever it might be, to enhance the overall function of a cell. If we can decrease that, or if we can improve that phase angle, thus decreasing the porous properties and leakiness of that cell, we could allow for greater surface area. We could allow for cells that have that higher integrity and higher capability to express certain factors that could indicate better function, better capabilities at the cellular level.
Now, does that change in phase angle pre or post exercise occur sooner for younger adults, say those who are below 40, compared to the change that occurs in older adults post exercise? Is that something that you've seen?
That's a good question. And I didn't group everybody by age categories when analyzing these data, but that's something that we can do. I'd imagine, just thinking of general physiological adaptation being more pronounced in a more youthful, in a younger age demographic, that we would see greater changes at a faster rate in those individuals, but I can't speak to that for sure.
Mm-hmm. Now, going back to your methodology of your research here and everything that played into it, we have a question that's wondering if the pre-test guidelines for bioelectrical impedance was followed by your participants prior to the assessment, and if not, might that be confounding your results?
So just to understand here, are you essentially asking that we use the InBody at the initial assessment?
I think they're asking if you followed the InBody testing protocol prior to the assessment.
Yes. So during that assessment, the InBody, and I apologize if I'm not answering it directly, but the InBody is integrated into our assessment. So part of our body composition analysis for our individuals involves them undergoing the InBody. So that's integrated into that aspect of their exercise-based assessment. It's done at that initial and then done every 12 weeks afterwards as part of that protocol.
Awesome. Thank you for commenting on that. And just on the InBody side, we do, of course, recommend following our testing protocol to ensure the most accurate measurements, just to kind of comment on that one. I have another question here that says, what would you recommend analyzing or looking at if a clinic did not have a 770 or the same access to the resources that you do have at the UNC? And how would you prescribe exercises and programs and track efficiency outside of phase angle, keeping in mind the effects of outside factors such as lymphedema?
Yeah, so with regards to not having access to an InBody, in terms of just general body composition analysis, so we implement skin fold measurements as well as body composition or body circumference measurements in conjunction with the InBody for our student interns. And the reason we do that is to give them the skills necessary to go into any facility, because like we're saying here, not every facility is going to have the InBody 770. So knowing what field tests or even knowing of other tools that can be used to measure body composition, to measure values that relate to lymphedema, having those skills is going to be important. I'd recommend that individuals who right now don't have the funding for something like an InBody 770 to explore options like skin fold measurement, body circumference measurements, what those do in terms of establishing a body composition value, what those mean with regards to lymphedema when we look at those body circumference measures, and developing those skills. They do take time to develop, but ultimately they are very beneficial for tracking changes in body composition, which if we see, or if we look back to how the ECW TBW ratio correlated to a decrease in percent body fat and how phase angle could potentially be predictors for that value as well as lymphedema, it would hopefully indicate that if this person's losing percent body fat, if their lymphedema is becoming better managed, if their weight, if their fluid distribution is changing, we're not going to be able to say directly without a device, but we could ideally infer that phase angle is also improving with those values. With regards to prescribing exercise, the biggest thing on that standpoint, for changing phase angle, would be combining a mode or a multimodal approach, doing a combined approach to exercise, making sure you're having an individual come in and they're performing aerobic training, but then they're also performing resistance exercise, which is shown to, increase phase angle over time. Incorporating other aspects of their fitness that would help them, move around throughout the day more effectively. That might not directly increase phase angle, but if phase angle is increasing with our other facets of training, we should be highlighting those as well, to give them a whole and well-rounded level of health and fitness after their whatever long intervention period.
Great. Thank you for sharing that. And as you mentioned, you do assessments, follow-up reassessments, tracking at your facility, similar as to what a personal trainer would, but of course focused on the recovery stage after cancer. How do you approach clients at your facility and use the data that they see from an InBody test to help them understand that it's not just them investing in an exercise program, but they're truly getting a return on their investment as well? What sort of tidbits do you think gyms made for where the general population could learn from what you all do at the UNCCRI?
Yeah, so the big thing we do is we're transparent with their results, with the client's results. So after we formulate that, after we do that assessment, and after we formulate their individualized program or prescription of exercise, we sit down with that client one-on-one at their next training session and go over what their results mean, how they performed at their assessment, the highs and the lows, what that means for their overall health, and why it's important that they buy into this program of exercise. Incorporating values from the InBody test goes a long way, because InBody is a body composition analysis, and for our individuals who come here, a goal that I see in 9 out of 10 individuals is that they want to lose weight. They want to, or some change in their body composition, whether they explicitly know that that's what their goal implies or not. So if we think specifically of the InBody or other body composition analyses, that's a great starting point for those in a dedicated rehab setting, or those who are in a commercial setting that might have a cancer program or not. That's going to be one that you're going to find with near everyone that comes in. So utilizing that data and explaining that data and your interpretation of it effectively is going to go a long way, because they're going to buy in. During that meeting that we have with them, we explain what all these results mean. We explain what our plan is. So outlining your plan for their however long 12-week intervention for us goes a long way as well. And then at the very end, after highlighting all of these factors and highlighting their plan and getting agreement on it, we have ourselves as the specialists and the client sign off on it. So not just showcasing the values, not just outlining your plan and being transparent, but physically writing down and formulating an established agreement really allows for that client to buy in, and really gives them the sense that they had a voice in how their exercise is going to be run. And they are in agreement with the specialist or trainer that they'll both put in the work to get there over 12 weeks or however long they're coming to that facility. So I think that those are some key factors: transparency, inclusion of as much analyses as of variables related to their goals, body composition in this case, and then having a mechanism of physical buy-in, whether it's signing off on something or not, are 3 factors that will really help in all settings keep a client engaged and motivated.
Great. Thank you so much, Nick, again, for taking the time to talk to us today. I know there are so many more questions you would all like to ask you, but unfortunately, we are coming to the end of our time together. Again, we're grateful for your research and for sharing the great work you are doing with Cancer Rehab. If you need to reach out to Nick, please use the email shown on the slide, nicholas.harman@unco.edu. And to all of our attendees, we hope this was both informative and inspiring, and that you will consider joining us in future webinars. If you do need to reach out to us, please contact us by emailing clinical@inbody.com if you want to have a conversation about applications, or if you may be interested in partnering with us in your research or sharing your research with us and others through this forum. Please contact us also if you need a certificate of attendance to apply for CPEU credits or CPE credits if that applies to you.